Good afternoon, everyone, and welcome to the 20th of the COVID calls. This is a daily discussion of the COVID-19 pandemic with a diverse collection of disaster experts. These calls are held every weekday at 5 p.m. Eastern Time. My name is Scott Knowles. I'm a historian of disasters at Drexel University in Philadelphia, and I serve as the host for these discussions. We are streaming live on YouTube. The link to this discussion can be found at the Scott Knowles YouTube channel, or you can email me or find me on Twitter at US of Disaster. Please do help spread the word about the COVID calls and send your suggestions for guests and topics. I've gotten some great suggestions. Please keep those coming in. Also, please feel free to suggest yourself as a future guest. You can also hear the COVID calls recorded as podcasts. Just go to the soundcloud.com website and search for the Slow Disaster Podcast. On Monday, we have Drexel University public health researcher Esther Chernak. Esther was a guest on COVID calls in the first week, and she's going to come in on Monday and give us an update of how things are going nationally with a focus on Philadelphia. And I'm also really happy to announce that we'll have Howard Konrother on Monday. Howard is the co-director of the Wharton Risk Management and Decision Process Center. He's been doing risk analysis since the 1960s. He's a tremendous expert in this area. And he has a recent article in Politico with Paul Slovic titled "What the Coronavirus Curve Teaches Us About Climate Change." So you will want to join that discussion on Monday. As of today, there are 1,677,256 cases of COVID-19 globally, according to the Johns Hopkins University Coronavirus Resource Center. This is up from 1,579,690 cases yesterday. 486,994 of those cases are in the United States, up from 451,491 yesterday. There are now a total of 18,022 deaths reported in the United States, up from 15,938 yesterday. There are also 27,612 reported survivors of COVID-19 in the United States. I have been asked frequently in these last months, as I know my historian colleagues have also been asked, what does history teach us that prepares us for COVID-19? It's a question that historians simultaneously crave because, well, people remember that we exist, but we dread it in another way, and here's why. Think of the challenge we all face in getting the story of this pandemic every day, the one that we're living through. I quote the numbers at the beginning of every one of the COVID calls, but behind each number, there's a person, a life, and there's a story behind the numbers, the lives of those who collect the numbers and who make those available, complexities upon complexities, stories upon stories. Certainly, the story of Trump in these days, or Dr. Fauci, certainly, will also appear in the history books of the future. But tracing out those millions of other stories, that's going to take some dedication, time, and creativity. Now, map that back in time with no social media, no 24-hour news, scanty government reporting at times, imperfect archives, and lots of gaps. So you can see why historians thrill at the chance to explain the past and then blanch a bit when we realize that we can rarely, if ever, deliver concrete lessons. And even if we did, people will receive those lessons differently depending on their own place in this world. But we do it, I do it, because I love it, because I believe that those historical gaps, those missing or muted voices, they deserve to be heard. And hearing them, even if they're faint, may very well make our lives better, or so we hope, so I hope. So I've brought a couple of historians on COVID calls today, maybe to commiserate with me a little bit on the role of the historian in the pandemic, and also to enlighten us from their own research in the history of disaster. Two very talented historians on COVID calls today. Let me introduce them now. Jacob Remes is a clinical associate professor of history at New York University's Gallatin School of Individualized Study, where he directs the nascent initiative for critical disaster studies. He is the author of the absolutely essential book, Disaster Citizenship, Survivors, Solidarity, and Power in the Progressive Era. And he's a co-editor with Andy Horowitz of the forthcoming Critical Disaster Studies, New Perspectives on Disaster, Vulnerability, Resilience, and Risk. My second guest is Julia Engelschalt. She is currently a doctoral candidate in history at Bielefeld University in Germany, and she's working on a dissertation project titled Climates, Contagion, and Comparison, American Medicine Between Colonial Warfare and the New Public Health, 1898 to 1925. Welcome, Julia. Welcome, Jacob. Thank you for making time to come on the COVID calls.
Thank you. It's a pleasure.
Thank you.
So I'd like to remind everyone, please ask questions in the YouTube live chat, and those questions will get to me throughout the conversation, or you can tweet the questions. People have been doing that successfully this week. Just be sure to tag @US of Disaster to get your questions in. So let's get started. Julia, thank you for staying up late and joining us from Germany. How are things there where you are? You're in Bielefeld, is that right?
Exactly, yeah. I'm not a native of Bielefeld. My family are in Berlin. Bielefeld, as probably a lot of people don't know, has about 340,000 inhabitants to this day, and is located in the northwest of Germany, sort of halfway between Hanover and Cologne, you could say. And it's quiet, not very surprisingly. We do not have a complete shutdown throughout Germany, although we are a federal system, or we have a federal system, and certain federal states have declared sort of a lockdown. North Rhine-Westphalia, which is the federal state that Bielefeld is in, has not done that. However, just my very limited perception of things, because I don't really go out these days all that much, is that grocery stores are open, but except for essential stores, pretty much everything has been closed. We have almost perfect weather. These have had it actually for a couple of weeks, so people are outside. We're allowed to go out on our own, or in groups of 2 people or households, that kind of thing. So whenever I take a walk or I meet with other self-isolating people that I feel safe around, parks are relatively crowded, but within the limits of social distancing. That's about as much as I can tell you. If you want to hear numbers, I can give you those because I looked them up. We're faring significantly better than the US at this point. That's as much as I can say.
Do you have the death totals at this point for Germany?
I do. Yes. So today, this morning, I looked it up. We were at 113,000 plus people who had been tested positive, and that's 5,300 more than yesterday. And out of those, 2,400 deaths. That's a plus of 266 as compared to yesterday. And I have to say the numbers are somewhat lower than the ones you probably have from the Johns Hopkins University, because we use our own, we don't trust American numbers, so we have our own registration system in place that's centralized at the Robert Koch Institute in Berlin. That's responsible for crisis management in these terms.
I don't want to necessarily ask you to answer for all Germans, but I'm about to. How is the public perceiving the government response at this moment?
Again, this is a very, very limited perspective, because I'm, sort of privileged in my academic, largely educated bubble, if you will. But my impression is, let me try and be all diplomatic about it, which is not my strong suit. But demand for scientific knowledge and expertise, and other expertise, I should say, is, from my point of view, is surprisingly high within the public, but also, and I think that's kind of the difference to the United States, it's part and parcel of government and policymaking strategy. So, that's not to say that there's, a united consensus on all issues pertaining to COVID-19. There are discussions going on, of course. There is debate about how useful certain measures and emergency plans are. But in general, my feeling is that, it's not a matter of the opposition or, other societal actors bringing demand for knowledge and for information to the government, but it's actually integrated in their strategy.
Well, thank you for those insights. Jacob, let me come to you. You're based in New York, but you're not in New York right now. I believe you're in Connecticut. Is that right?
Yes, I'm one of the New Yorkers who have probably read about in various articles who went to practice social distancing out in the country. So I am in rural Northwest Connecticut, where even on days when today it spent the day hailing, but even on days when it's not precipitating, it's very easy not to see anyone all day or to be very far from people. It feels much like Litchfield County always does, which is to say, like rural New England. There are definitely more New York license plates than usual. This is it's a common vacation place for New Yorkers. I just looked it up. There are about, I've lost it. There are 315 confirmed cases in Litchfield County, which is a county with about 180,000 people. No big cities. And there have been 13 deaths. But that's also, it's clearly very early in the curve here. There are no recovered cases. There are still 302 active cases. So we can expect that to get worse. But also it is a place where even during ordinary times, you kind of have to try not to be distant from people, which is why I am here, which is why it's a place where people want to be at times like this, because you can do that.
Is NYU completely closed down, or they still have staff, grounds people coming in? What's the situation there?
So they still have some essential workers coming in. They have, I believe, one dorm open for the people who would otherwise have been homeless, and those people are being fed in some way. The classroom buildings and library, all the academic buildings are closed off such that even our ID cards would not let us in. And of course, NYU also has, in addition to dorms for students, there's also a lot of, many of us live in essentially in faculty dorms, in faculty housing. And those are all still active, although I'm told that they're kind of largely emptied out as people like me have gone to try to be in other places, which on one hand is obviously a great act of privilege that I have to be able to do this. It also is decreasing density in tall buildings. So I live in a building that ordinarily, just to leave, I would have to be in a small elevator for 26 floors for a few minutes. And so kind of each family that leaves is actually making, or at least this is what I'm telling myself, is actually making it safer for everyone who is staying.
Yeah, no, well, that makes a lot of sense to me. And I'm thinking about Litchfield County and places like that. And we've been waiting for the sort of rural story to be told, but the rural story in the American media is often framed as rural Kansas. And the reality is there's rural New York State, there's rural Connecticut, there's rural New Jersey. I think those numbers, I'm glad that you both gave me those numbers to think about. And even though the population density may be low, there might be only one grocery store. There might be only one of anything that's needed. So there still might be a lot of density in certain important nodes. Have you noted that?
So the part of this being part of the history of Litchfield County is that actually 200-ish years ago, it was actually an industrial area. It's where a lot of the iron that was turned into cannons and guns in the Revolutionary War came from. And so there are these various small towns, each of which have a grocery store, each of which have a little bit of infrastructure. There's not a lot of hospitals, but in fact, I haven't actually looked it up, but I believe that there's actually a relatively higher number of ICU beds per population than there are in many cities, just because there aren't very many people here. So yes, there's certainly nodes that come in, and when you go into town, you see the churches are closed. They all have signs up about worshiping online. The libraries are closed. The grocery stores are open and seem to be doing when we have gone on our weekly grocery shopping, are doing a very good job of trying to enforce distancing, having masks. They've all put up the plexiglass in front of the cashiers. The biggest grocery store is unionized, and so I kind of feel more comfortable knowing that workers there are more likely to have be able to take sick days, or have a voice at work to be able to demand more safety equipment and more shields for themselves.
Mm-hmm.
Plus, it's actually a larger store, so I'm more able to navigate it without running into other people.
Mm-hmm. All right, well, thank you for that update from rural Connecticut. And that's about as much of the present as any of the three of us can probably stand to talk about. So let's talk about the past. Julie, I'd like to start with you. Really want to know about your dissertation project. Just dive in, tell us the kinds of historical puzzles you're working on, and if you can, how those connect up for you to some of the things you're seeing happening right now.
Right, okay. So first of all, I think what I have to emphasize is that I'm not technically, I didn't start out being a disaster researcher of any kind. But as it happens over the
none of us did. Almost none. There isn't. It's not a thing. I mean, it's a thing now, but it wasn't before.
But I guess a lot of the things that I work on over the last couple of months, I should say, even before COVID-19, but of course over the last few weeks that has sort of been catalyzed. A lot of the things that I do have to do with public health crisis management, and I feel that the rhetoric of crisis is becoming more and more intriguing to me, both generally in history, but also like in the actual work that I do. So I want to start out maybe with two basic observations that kind of sparked my interest, and that's where my project kind of comes from. The first one, very generally, is the sort of standard narrative of bacteriology, laboratory bacteriology, rising in the mid-19th century, that is commonly, at least in the history of medicine, perceived as having erased most of, if not all, previous theories of disease causation, and among them climate, which is what I'm interested in. And at the same time, or say another observation that struck my interest was that climatic determinism is actually extremely salient, especially in US American medicine and science at large in the early 20th century. So well after the emergence of germ theory. And that's kind of how my argument came about, which is that American interest in climate has a lot to do and is fueled to a large extent by US American overseas colonialism, which starts in 1898 with a victory of the United States in the Spanish-American War, and the acquisition of, among others, Cuba, Puerto Rico, the Philippines, and somewhat later, and with a different legal status, I've also added Panama to my project. And so I look at two things, essentially. I look at how the American tropics are constructed in American colonial medical research and public health interventions in the colonies. And then I take that back home, so to speak, not my home, but your home, to the continental United States. And I look at how that colonial knowledge was transferred and adapted to the domestic context. And particularly in that context, I'm interested in how the American South, which has a tradition of being perceived as diseased and backwards and also, climatically different, how that space of the American South was sort of re-tropicalized, if you will, or how that tropical discourse is reinvigorated through medical research and public health reform in the early 20th century. So again, I don't specifically deal with pandemics either, I should say, but with responses to relatively contained outbreaks, mostly because the colonial ones happen on islands and can be largely contained by implementing quarantine, etc. But since you asked for perhaps a specific case, right now I'm very much interested in mainland continental public health as it pertains to pellagra, a largely forgotten disease, I get the feeling, although it's quite horrifying actually, and it flares up in the early 1900s in the rural South. It's a disease associated with poverty, and by that I mean extreme, like poverty. And it has a horrifying look to it, and it creates, it has this red rash on patients' faces that looks like a butterfly, which is why it's called the butterfly disease. And a lot of things are not known. It's a new disease to the United States in the early 20th century. So there's a lot of non-knowledge and uncertainty going on there. Causation is not clear. Based on bacteriology, a lot of people are looking for an agent, a microbial agent, and they can't find one. It's actually a nutritional deficiency disease, putting it in a nutshell. And it creates widespread panic across the South and among public health officials dealing with the southern states. And it also has, if I may just briefly refer to the early 1920s, which is when it really flares up again after it has actually been sort of contained for a while or mitigated. It flares up after a bad harvest, after a bad winter. It's actually predicted by one public health service official who could have been the Fauci of that time, except his colleagues from the state boards of health from southern states are actually furious. They give him a very bad rap about, you know, bringing that to the public and, you know, as they say, creating a bad image for their respective states. So there is a lot of, you know, a mixture of health officials at the same time acting as political agents, and I think that's something that's come up again and again in recent, you know, media discussions that I've followed.
What kind of, what kind of sources are you relying on there? You got state by state public health records, or are you following narratives of particular doctors, or how are you putting it together?
Well, I mostly follow specific doctors, and I'm particularly interested in those doctors that have been part of the military in the Spanish-American War and that sort of use that, you know, existing medical reputation and combine it with growing reputation of military representatives. I try to follow as many as possible across colonies. So I'm interested in how their knowledge shifts, for instance, from, you know, being stationed in Puerto Rico to the Philippines and then to Panama. And also I'm looking at ex-colonial officials that are now, you know, later in the early 20th century employed stateside and take up various offices from, you know, professional and labor health to children's health to tropical medical research, actually public health service, which is an outgrowth of the military, really. So yeah, I try to put together a sample of doctors that I follow, and at the same time, you know, I'm always trying to tie the stories I tell to, you know, one specific disease or two in relation to each other in order to, you know, get a grip of the materials. And so I'm combining, especially for the first part, for the more tropical part, if you will, for the colonial part, mostly scientific journals, but also personal documents, letters, you know, administrative documents are a large part of the second part of my dissertation. So public health service, Rockefeller Foundation, the Sanitary Commission for the Eradication of Hookworm, for instance, one of my favorites. So a lot of official documents. It's not a history from below, I'm afraid.
How did the American imperial doctors view the public health apparatus that they stepped into, the legacy of the Spanish public health, either in the Philippines or in Cuba? This is a question that came up when I talked with Cindy Remes, and Christina Fryer had a great conversation with them 2 weeks ago. And this question of when there's an imperial turnover and the new colonizer comes in, what's the perception of the old medical knowledge? Is it somehow sympathetic? Is somehow competitive? Is somehow discounted? Do you encounter that question at all in your work?
Yes, I do, actually. And there's been quite a bit of research on that because, you know, the Americans are sort of late arrivals on in the imperial arena, coming in 1898 as they do. And there is a lot of, you know, I get the sense of sort of feeling of inferiority and of having to catch up with the others. It's much like Germany in the 1880s, really. And so the main idea is that the Spaniards were bad for, especially, I mean, Cuba, the Philippines, Puerto Rico, especially for the Philippines, actually. The notion is that there was no sanitation in place in the Philippines, which isn't true. There had been the beginnings of a sanitation system, a sewage system in Manila City under the Spaniards. The perception is that they were all, Catholic and keeping everyone, including themselves, in total backwardness, which when you look at sort of how bacteriological knowledge travels to the Philippines, totally is not true, because a lot of Filipino elite members had studied in Spain in the 1880s and also in France, and have brought back those new insights, which were at the same time being heatedly debated within the United States. We're not sure. Climate maybe has to do with disease causation if it's only microbes that are responsible as etiological agents. So there is a black legend being created, a legenda negra about the Spaniards. Yeah.
Well, thank you for that, Jacob. Let me come to you, ask you about the place of pandemic in your own work. If you want to talk a little bit, or disease in your own work, talk about disaster citizenship or your current projects. How does your work intersect with some of the things that are unfolding in the headlines every day right now?
Yeah, that's a good question. I ask myself that a lot. So my first book is about two large-scale urban disasters in North America in the Progressive era. One of them is a citywide fire in Salem, Massachusetts in 1914. That makes about 18,000 people homeless or jobless. It, depending on sort of the source, maybe 6 deaths are attributed to it. In Halifax, Nova Scotia, a few years later, in 1917, there's a ship explosion, a munitions ship bound for World War I, that kills about 2,000 people, makes about 25,000 people homeless or jobless. And my book is really about working class response to those two disasters. How did people seek to simultaneously maximize the aid that they got from the state or from churches or from civil society, but mostly from the state? How they try to maximize the material benefit that they got while trying to minimize what the state tried to get in return, which was authority and control over their lives. And one of the, and so neither of those clearly are about health. In the dissertation, actually, I don't even think it made it into the dissertation version. In a very early version, there was a lot of, in Halifax, there was a lot of discussion about tuberculosis. Tuberculosis was the major public health crisis in North American cities at the time. It is actually still the major public health crisis in the world. I always feel like I need to remind people as we're thinking about one lung infection that 4,000 people died today of tuberculosis. 4,000 people died yesterday of tuberculosis. 4,000 people will die tomorrow of tuberculosis. And this is a disease that we have known how to cure for 70 years. Tuberculosis kills more people every year than HIV and malaria combined. So in some ways, thinking about tuberculosis in North America 100 years ago is a reminder that tuberculosis continues to kill vast numbers of people. And that the things that we could choose as a world, we don't choose, but we could choose to cure tuberculosis roughly in the same way that we did in North America, which is making people richer and improving their houses. That's not how people with money choose to try to solve tuberculosis now in poor countries. But anyway, so there's a lot of concern about tuberculosis, particularly in the aftermath of the Halifax explosion, because there's concern about sort of weakened bodies. So one of my favorite stories that didn't make it into the book is somebody who is weak and tubercular after the explosion, has kind of a nervous concern, neurasthenic in the parlance of the time, and she gets sent out to live in the country in a tent over the summer, with the firm instructions that she is to drink a pint of cream and a dozen eggs every day and nothing else. And you can see, I mean, in fact, you can see why tuberculosis is often experienced as a wasting disease. People lose a lot of weight, they can't keep weight on. And so if that is what you are treating because you don't have antibiotics yet, then you try to make people eat cream and milk. Still, it's a little bit hard to imagine that diet for a summer.
Yeah, absolutely.
But what you can see in that is a way in which disease was experienced and was treated spatially. So the city is seen as unhealthy, you go to the country. In Salem, it's the presence of disease or the fear of disease is somewhat different. So one of the things that I write about is relief camps. So there were in Salem, there were two relief camps that were set up by what was then called the militia, what was about to be called the National Guard. Mm-hmm. And these were camps that were set up for kind of obvious humanitarian reasons, right? There was suddenly a shortage of houses because houses had burned. There were all these people who were homeless, who had very little money because their jobs their factories where they had worked had also burned down. So where did they live? Who has tents? Tents are the purview of the army, so the army pitches tents. But of course, what you see then is actually living outdoors in a camp under armed guard is not particularly pleasant for anybody. There wasn't a lot of space. You got one tent per family. It rained a lot of that summer, so everything was damp and muddy, and there was this pervasive fear of disease. So in the newspapers, there are these constant kind of arguments between, arguments isn't quite the right word. There are these constant confrontations between the militia and the residents of the camps about cleaning them up. And so these fights about control, about behavior, about comportment. May you throw your trash around in your own neighborhood. May you be drunk. May you, who should be in charge of feeding babies at night? All of what is the proper system of sanitation for going to the toilet? All of these questions about kind of how to arrange your life intimately were literally policed by these armed young men with the rhetoric of public health, and that public health became one of the registers through which the government tried to regulate people who needed housing. Mm-hmm. But it also worked the other way around. So one of the stories in my book is about a community of Eastern European Yiddish-speaking Jews who immediately after the fire go and live on the second floor of a building above a furniture store, and where the plumbing doesn't work. And so they send a representative to the headquarters of the relief to ask for a plumber. Someone from the army or someone from the militia comes back, looks and says, this is squalid. No, this is not fit for human habitation. This is this is going to cause disease. This is going to be a public health crisis. So the government really wants the people who are living there to go into the tent city. And because that's what the state wants, the community is able to negotiate for more power in the way they're going to do it. So they say, well, we don't want to go, but if we're going to go, we want our own section. We want our own cook so that we can keep kosher. Mm-hmm. We want to be able to control our own little corner of the camp. And the concern about public health was such that they were able to extract these concessions from the state in exchange. So it was kind of part of this negotiation process. So the public health concerns went both ways. It's one of the things that I like talking to my students a lot about, is how we like public health. Public health is important. My wife is an epidemiologist. She cares. I kind of therefore am required to care a lot about public health. But also public health is based in public health at its heart is about how do we get people to do things that aren't about us, they're about everybody else. Right. How do we get, when I go out wearing a mask or when I go out and stay 6 feet away from people, it's mostly not to protect me, it's to protect everybody else because I might be an asymptomatic carrier of COVID. So how do we get people to do these things that aren't about them, that are about somebody else? And for oftentimes in the American experience, the way we force people to do things is through the threat of violence, whether that violence is physical shooting people or hitting people violence, or the arresting them and putting them in a cage violence. But I think one of the things that disaster history and that pandemic history and other sorts of public health history can show us is ways in which we have been more successful in getting people to do things for other people on the basis of solidarity and on the basis of kind of we're all in this together, rather than on the basis of compulsion and coercion.
I've been thinking a lot about your writing about Salem and the camps, and I've been thinking about Joanna Dill's work about San Francisco after the earthquake, and other work that looks at these seemingly improvised spaces of relief camps. But that when you really dig in and analyze them, you see sort of broader social clashes around regulation of the public. And it's usually the people in those camps are the people who don't have means to be somewhere else in that moment. And so the camps, and I think this is true today in the discussions that emergency managers and public health officials have about how best to manage relief camps after Hurricane Katrina or after Hurricane Harvey or whatever it may be. These are sites where you see broader societal dispute taking place. But that's vexing to me in this moment of time. I don't know how we find those kinds of fault lines at this moment when everyone is basically sheltering in their own, in their own domicile. I mean, we could look at homeless populations or other people who don't have the ability to follow public health regulations and be in their own homes. But I wonder, and I guess a question for both of you, about historical method in this particular moment. I mean, how are we going to gather the data, build the archive of this particular moment in time? It's going to be so different from the kind of archives that both of you have looked at, right? I mean, what kinds of changes do you predict in the way that historians looking back at this moment are going to be able to work compared to what you're working on looking back? Julia, can I put that to you first and then to you, Jacob?
All right. Well, I guess, on a very broad level, the type of sources, and again, there's a lot of inequality and privilege there, I think has shifted largely, especially when you look at, everyday history from below, has shifted or is shifting to the digital realm, which presents its own, challenges in both archiving them and then also working with them, retrieving them. The sheer mass of data that could potentially be interesting and relevant is just overwhelming to me right now. I mean, that's something I try to save for another day because it would just make me nervous, I guess. So of course, in a way, looking back at largely, paper and some objects and maybe photographs, that's all limited and within a certain enclosure and put into neat little boxes. And I think that's something that won't really be possible anymore. Not just about COVID-19, but about sources from the recent years, I'd say. Something that I can tell you that has been going on for a couple of weeks only, it can only be a couple of weeks, in Germany, in the German-speaking context, is the Corona-Archiv. So an archive that's specifically directed at the public and asks people to contribute any and all sources that they deem valuable for keeping them and maintaining them for future reference. So that's photographs. I've had a brief look at the website, but to be honest, I haven't really had time to look at it in detail. Textual material, videos. Actually, that was one very interesting thing from my hometown, my city of Berlin. City center, a usually very crowded space that has been, filmed now with a cell phone, and that's just empty and very, very quiet. So these documents that show us the before and after, I guess, that might be something that would be really valuable. But then again, being able to produce that kind of archival material again has, inequality implications. Not everyone has access to that technology. I mean, we're also talking about our students perhaps not being able to follow online classes, which are starting here in 2 weeks. So that kind of access issue and inequality issues that are relevant in this context, I think, we'll have to address them in some way, but right now I don't have a perfect answer.
Yeah, no, I think we're all groping for the answers along these lines. I've been thinking a lot about, I wasn't aware of that archive. What's it called again?
Corona-archiv. So it's like a portmanteau of Corona and archive.
Got it. Corona archive. Yeah.
Yeah.
And Jacob, I mean, thinking again about the kind of sources that you've relied upon in your work. I mean, there's sources that show solidarity, they show dispute, they show strife, they show community formation. I mean, are we producing documents like that of this time? How is the archive changing?
I mean, I think, as Julia said, there's simultaneous, and maybe everyone feels this way, whatever time they're in, but simultaneously, I mean, I worry a lot about history won't exist and they won't have jobs, and there are lots of reasons to worry about them. But one of the reasons I worry about them is how will they deal with Twitter? How will they deal with Facebook? Will those things in 100 years, or will technology have changed such that the things that we produce and store in the cloud are totally inaccessible? But even if they are accessible, I can't, as a century who deals with papers and who knows what I don't see, right? Because I have my archive and that's what's there. Imagine trying to trawl through Twitter, figure out how to use millions, billions of these short tweets. The other disasters very often make things visible that were visible to some people before were perhaps easily ignored. So I mean, and what these are often about class and gender and citizenship status and the standard and cleavages of society and of. But I think one of the things that we can see now is who is essential right now. What is the work that is being done? But it's not. It's care work. It's people who are working in hospitals, not physicians and nurses, but orderlies and personal care assistants and people who are cleaning and people who work in the dining halls. It's people who work in supermarkets. It's people in school lunches. It's that is about distribution and about and delivery workers, right? So distribution and really explicit care workers. And those people are often paid very little money, performed by immigrants, people of color, women, the combinations of all those women of color who are immigrants. And I, through at public archives or newspapers, right, future historians will be able to see that and to see how we have started or that care becomes so obvious. How will we, looking back on where we are now, how will middle-class families rejigger the informal care of their own families when schools are not providing childcare and parents are having to simultaneously work and provide childcare? Our papers.
Jacob, we've lost you here on our connection, I'm afraid. I've taken the video off in the hopes that we might get a slightly better connection there. Can you still hear us?
Can you hear? I can hear.
We're dropping you out about every 5 to 6 seconds, unfortunately.
My is now, it was red, is now white. So perhaps can you hear me?
Yeah, we can hear you. It's just, unfortunately, it's kind of fading in and out here a little bit. Let me see if you can just start to come back on, bring your video back on, and maybe that'll help us out a little bit. But I think
all right. Is this good?
Yeah, we'll keep trying with it.
What I was saying is that things that disasters do is it make makes questions and contestations so few historians will be able to see, or how did we not come to terms and change society to think about families deal with taking care of their children when all of a sudden schools weren't there. How domestically did that work get done? And I think that we start what historians will do for the papers, people writing about and in their past, social workers and social workers notes, but they will also have hopefully they will have all of the social media.
So I think we caught the thrust of it. Maybe we should go off video with you just for the remainder of time so that we can maximize the bandwidth there if we can get audio. But I want to come back to, so first of all, I want to remind everybody that we're talking about pandemics and history and disaster today with Julia Engelschalt and with Jacob Remes. And Julia, I want to come to you. It's a question for both of you, really. What I want to come to you first, back to this question of crisis as maybe a category of thinking that is operative in different historical settings. And you said earlier on, it's a topic you've been thinking about, sort of moments of crisis or how crisis is formed and maintained. Could you talk about that a little bit?
I've actually only just started, getting my reading list in order and sort of working through that. But what I can tell you, what my impression is that crisis as a rhetoric is very much a term that's used as modernity unfolds, as there are states in place that are able to perceive a crisis as such, and to address it and to establish more or less centralized measures of sorts. Although when you talk to Cindy Remes, I think earlier last week, she pointed out a case in the 1700s, which in France, with a very centralized effort to mitigate public health problem there. So I was quite impressed by that, because my impression was that that centralizing effort in mitigating crisis should have happened later, so to speak. So it was interesting to see that, but the rhetoric of crisis, I guess, actually does come in a little later. And it comes in also when there are states in place that can be invoked to help out. For instance, in the United States, declaring a state of emergency will, grant you access to federal funding, as far as I know. And something similar is going on here. We are a federal system, and there are certain, things in place that, under normal circumstances, prohibit individual federal states to apply for government funding in certain regards. So, calling something a crisis actually makes a lot of sense when there's something to get out of it. And I think Jacob also alluded to that earlier. Now, interestingly, just to give you one example of where it doesn't show up and where it then does, my impression is that my American doctors, when they go into the tropics, they don't talk about crisis. That term doesn't really, I haven't seen it in the sources. And then I thought about why that is, and the explanation that I've come up with is that basically tropical spaces, environments, and all the disease hazards, that's basically from the perspective of white bodies coming in, and the belief is that the tropics do harm to white bodies. That's a crisis, that's a generalized perception of crisis. It's a health hazard, a catastrophe just about to happen. You stay there for two years, and if you can make it until then, you will get all neurasthenic and melancholic and mentally and physically debilitated and whatnot. So there is no need to talk about a crisis really, because it's there in the outlook onto the tropics.
Mm-hmm.
But in the early 20th century domestic public health sphere, like I said about pellagra, there are moments where the word might not be there, perhaps because some of the incidences I'm looking at are more localized or treated in a more local way. But a sense of urgency is certainly there, and a sense that the US needs a sort of centralized, standardized system, both in statistics, but also in administration. So we need to know our numbers so that we can we know what we're actually talking about, and then we need a centralized reporting system of those numbers, monthly, weekly, monthly, quarterly, annually. And then we need people to deal with those numbers largely in administrative terms and do something about it. So that's a process that I can see is unfolding there. Although I think the rhetoric of crisis, as my colleague Christian Boylan pointed out in a recent op-ed, unfortunately in German, there is a proliferation of crisis rhetoric going on over the last decade.
Mm-hmm. I want to stay with this theme of concepts that may be traveling across time when we think about pandemic and disaster. And Jacob, I want to ask you about welfare as a category. Something I know you think about in your historical cases, but also seems to be very much, maybe this is a moment of reconsideration of what the welfare state means in the United States. What do you think?
Yeah, so there was a very influential book 7 or 8 years ago, called The Sympathetic State, Michelle Dalbert, who's a historical sociologist and law professor at Stanford, who makes that the U.S. welfare state was disaster relief, that there were congressional appropriations that gave directly to those who suffered disasters. And one of the reasons for this is that one of the things that makes a disaster is that it scrambles the category of worthy and unworthy poor. That rarely in kind of Anglo-American history of welfare, there's this very firm distinction that people who are, which is to say, who are poor through no fault of their own, largely because often it kind of gets parsed as people who are or imagined to be, that they are deserving of support. They can deserve support. Sometimes they can even get cash support.
The worthy poor. The worthy poor.
You're saying poor.
Yeah, right.
It's the worthy poor, the deserving poor.
Yeah.
And that unworthy poor, the undeserving poor, have to be fit into. And one of the things that disaster, big group of people who had been who can be seen as worthy poor, because there's this clear event that happened that forced them into poverty. And so even now, right, we see for someone who a hurricane or a tornado, rather than someone who has no home because has made it so that they can't afford a home. One of those people gets disaster relief from the federal government, gets a lot of donations. The other gets is homeless and put in a shelter. If they're lucky. And so one of the things, so disaster creates more generosity. It has a whole separate infrastructure and bureaucracy of giving out aid, but then it also creates a lot more people who get put under various welfare bureaucracies. And there's all of this concern of, well, is this person poor because of the disaster, or is this person poor because they're unworthy? And therefore, investigations of people who are not used to being investigated. So you start seeing, as we saw a few weeks ago in the United States, when there was concern about how much money people would be given in the first, or in the whatever number stimulus bill it was, was it reasonable to give it out based on the 2008 or the 2018, 2017 tax returns? How could you be sure that you were giving money to the right people?
Yeah.
The things that disasters allow us to do and allow us to do is say, well, maybe people should be getting support anyway, right? So we are starting to see in a much more mainstream way the idea that there should be a universal basic income. We are starting to more mainstream idea that housing should be deep and there should not be evictions, right? So it changes because there are all of a sudden more people who need support. It changes the way people imagine support, creates new places for conflict.
Mm. I wanted to, I mean, one of the things that I think those are great insights. One of the things that I find always kind of challenging in telling American disaster history, and this may be applicable to Germany as well, is you have to tell, there's a federal story to tell, and then there's a state-by-state story to tell. And particularly when we talk about the welfare state, I mean, to me, it's really a 50-state and 7 territorial disaster from a governance perspective in the United States. And I wonder, you know, it's probably going to be the case that reforms to the welfare state in the US are coming as part of this. Some of them may be lasting, but I think it may be very uneven in the way that those are applied from California to New York to Alabama to Arkansas. And I don't know, I mean, Julia, is there a rhetoric around that in Germany as well? Is this somehow seen as both a national and a regional disaster, or maybe more generally a German versus a more European disaster? You know, that the German experience is going to be different from the Spanish experience or the Italian experience, and that somehow speaks to the way the welfare state works or doesn't work in Europe right now.
Kind of a big, that's 2 questions rolled in one, right?
It was 4, actually. I think I lost track after 3. Yeah, but I'm just trying to get to this. When we talk about crisis or welfare, we're really also talking about scale. And so we're talking about at what scale and who gets to weigh in to the provision of help or the provision of power, or however that works.
Right. So, I mean, I guess one thing that always flusters me when I compare the U.S. and Germany and their federal systems is much less, you know, the administrative bureaucratic differences in the way these federal systems are set up, but it's actually like its size. I don't see us as, you know, separate states, mostly because, you know, from here it takes about 1.5 hours and I'm in the next country. You do that in the United States, chances are you're in New Mexico or Texas, but, you know, not in, well, I don't have to give you an example of that. So we're small, just in terms of area, the area that we cover. Although I have to say that public health, just like education, falls under the jurisdiction of the federal states in normal times. Now, and then when you do that upscaling move to the European Union, there is no EU unified health policy in place right now. So we are talking about that. And within, I'm sure not only Germany and the US, but also in other EU countries, we are talking about general basic income and these kinds of issues. I'm pretty sure that, you know, perceptions of welfare and of EU member state solidarity are very different across different member states. So, you know, whoever from Italy, you know, was flown into a German hospital to get a cure for, or, you know, to get treated, I should say, for COVID-19, I'm sure is thankful. But then again, there's a lot of other things that Germany doesn't do. Also, you know, the border closure of, like, outside the EU and not letting refugees come in anymore. And when you look at Southern Europe, from what I've heard on the radio, I think 2 days ago, there is another crisis, that is the financial crisis of 2008-9 and the following years, that's sort of invoked and brought up again in national discourses, for instance, in Greece, apparently. And the sort of trauma associated with being treated the way these countries were treated by the Troika and by the bailout plans, etc. So where was I going with that? It's complicated, I guess. But yeah, I guess we're largely talking about very similar issues, albeit from, I hate to say it, but a much higher level of the kind of welfare state system and social security and all that's in place over here.
You can say it. We need to hear it over here, absolutely. And if this moment sparks that conversation in the United States and it catches on in a real way, in a bipartisan way, that will be some small silver lining to this historical episode we're living through. We're almost up on time. I want to get one more question in to both of you, because historians are supposed to think a lot about beginnings and ends. We think about time. That's our stock in trade. And I've been thinking about this a lot too, how the COVID-19 story, how we will tell it, how it will begin. And all this week, I've been asking guests on COVID calls to help me think a little bit about how it will end, or how you're looking for an ending point for it. What kinds of moments would you be looking for to say, okay, this is approaching some sort of a closure or a place where we can make sense of it? Jacob, I'm gonna put that question to you first, and then Julia to you. How will we know when COVID-19 pandemic is over?
Well, so I have two answers, one of which is unfastic, and one of them is less optimistic, is also optimistic but less so. One will be if the United States manages to have mass testing and a of case identification, contact tracing, and case isolation. Because this is, of course, multiple disasters at once. There's a public health disaster. There's also an economic disaster. And with that, the social disaster, the upending of everyone's lives. And if we were to be able to do what South Korea did, which is they test who are suspected exposures, see who is sick, see who they with, and isolate that cluster, we could do that. And there is nothing but political economy preventing us from doing that. It is, as Taiwan and South Korea show, it is possible to do that in a democracy. To do that, my impossibly optimistic answer is this ends when we do that. So optimistic, but less so, outrageously so version is when we get a vaccine and we can protect ourselves. But I describe those both as optimistic because one of them I don't think will happen, and the other, who knows when it will happen.
You don't put
Very
a lot of
long lasting.
Yeah, your confidence level in the United States, at least rolling out a rigorous testing regime, is low. Obviously, the vaccine production will come. So we may be looking at least another year of this going through different waves. That's how you're looking at it?
Yes. Well, I am a virologist or an immunologist.
That's okay.
But I am, I do see increasing, I don't know, I think a year for a vaccine might very well be optimistic.
Well, I appreciate your caution for historians to stay in their epidemiological lane. At the same time, though, we do have responsibility in part to build on historical cases to understand inflection points, because the way the public understands those inflection points is political. It's scientific, but it's also political. So if we can draw on historical cases to help us understand the formation of those inflection points, I think it's totally appropriate. So I learned a lot from your answer just now, and I appreciate that. Julia, same question to you.
Well, I mean, all of what Jake said, I guess, plus, I'm thinking more in waves right now. So I'm actually curious to see if it's does come, like if we can actually draw that parallel to the 1918 pandemic, influenza pandemic.
A second wave, which some people are talking about coming in October, November.
Exactly. Also, I am curious to see how vaccines / also treatment development will be developing. I guess one major point now, like an immediate one that we're all waiting for in Germany, is in fact when the question of when emergency measures will be lifted, which there is a lot of talk about that, and about the sort of gradual return to normalcy, whatever that is supposed to be. And whoever is actually going to benefit from that, of course, all parts of the economy that are now being on the verge of existential crisis, if not there yet. So freelancers, people who are not like me, having their paycheck come in at the end of the month, and that's that. So, and I guess the other thing that I'm like very personally just waiting for is that point in time when I can actually go see my family again.
Right.
Because I have an immunosuppressed dad, a recent cancer survivor. They're in Berlin, and there is no way I'm getting near them, which for now is fine. But that moment, I think, for me, and I don't think I'll be the only one. That's the thing. I think that too will sort of be a collective experience of when people will actually be able to see their loved ones again that they can't see right now, and that will be part of writing this history, on a micro historical level, if you will.
Can I give you a slightly more optimistic answer than the one I gave before, Scott?
Yeah, you've had a couple of minutes to have your faith in humanity restored, maybe by Julia's amazing answer she just gave about the need to restore human contact. Yeah,
exactly. Well, it's that I actually think that when future historians periodize, my hope is that this is the inflection point. And like all periodization, there won't be a particular day, but that in the same way that I as a historian of the United States, you and I as historians, all three of us are historians of the United States, can look back and our main task, I think, as historians of the modern US is to say, how did we get to the point where we have such great racial disparities in both COVID infection and COVID fatalities? How did we get to the point where we don't have any production of N95 masks in the United States? How did we get to the point where the people who do this crucial labor of taking care of us and keeping us alive are so ill paid and so precarious, right? How did we get to the point where we have a malevolent clown as president? That's the story that historians can tell now. And I hope my optimistic answer is that historians of the future will say, oh, well, there was this terrible post-war neoliberal, whatever you want to say, moment in which the United States tried to destroy itself. But then there was this turning point that we look back on as the COVID pandemic. And that's when the ship started to right itself. That's when they started to realize, and they started to organize, and they started to restore the capacity of the country to take care of itself, the political capacity to govern itself, the social capacity to take care of itself. So my optimism is looking at my students and looking at the conversations that they're having and the way that they are thinking about what is necessary and how to take care of each other and themselves. And I hope that they take this experience that's going to shape their adult lives and rebuild something that is more sustainable.
Yeah, the continuity that I'm hearing in the urgency of discussion around climate change, even in this moment, is also giving me that hope as well. I'm really seeing a lot of people sticking on the case, not to see this disaster somehow separated from the other disasters, slow disasters of poverty, of climate change, and the ways that they actually compound and exacerbate each other. I can't imagine a more optimistic way actually to end this really extraordinary week of discussions, Jacob, with your clarion call to actually have a little faith in the rising generation in the political economy to right itself. It's going to be a whole new section in the textbook, that's for sure. And Julia, you're sharing with us the need to have that sort of reaching out. The disaster ends at the moment that we can reconnect in ways that we've seen as to be crucial to keep our humanity in all this. I want to thank Julia Engelschalt and Jacob Remes for spending time with us today to talk about pandemics and to talk about disaster and to talk about history. And I want to remind everyone that the COVID Calls takes place every weekday at 5 p.m. Eastern Time. And on Monday, we have Esther Chernak to give us an update on public health in the United States, and also Howard Conrather of the Wharton Risk Decision Science Center to talk about risk analysis and human psychology. Thank you both for being with me today.
Thank you so much. Thanks for putting up with my bad bandwidth.
No, it all came back at the end and it sounded great. Thank you very much and stay healthy, everyone. Goodbye.
Bye.